If physical therapy and medication do not alleviate your joint pain, what are your options?
On this week's Health Talk, orthopedists will discuss the benefits of a minimally invasive robotic procedure for hip and knee surgeries.
Stay tuned to learn more about this innovative treatment option. We're up next.
Hello, I'm Dr. Vicki Smutak.
And I'm Dr. Eric Mazer. Today we're going to talk about knee pain, a very common problem. Joining us is Dr. Robert Deveney. He's a total joint specialist and hip and knee surgeon with Danbury Orthopedics. I got through that. And his patient, John DeMeyer. Welcome, gentlemen. Nice to have you both on the show.
Thank you. Thank you very much.
Yes, thanks for coming. So we're going to hear a lot about this new procedure that is very, very precise for different types of joint replacements. But John, let me start by asking you, your problem was in your knees.
Both knees.
Both knees.
Yep, had problems for a long time. Best way to describe it is going upstairs or bending my knees sounded like Velcro being torn apart.
It must have been painful also.
It was painful, and just weak joints, felt weak, and just a lot of discomfort. Had to give up doing a lot of things that I used to do.
Which is such a common reason to go
Yes.
see the orthopedist, right?
Absolutely.
Yeah.
So did you try physical therapy and medication, the things we had talked about in the introduction?
I had over the years, I was told at least 10 or 15 years ago that you're going to need knee replacement surgery. And of course, in being in your mid-40s, I pushed that off and push it off and push it off until finally.
Because you don't want to hear that.
Exactly, you don't want to hear it. And then I finally got to the point where, due to a injury, I just didn't have a choice. And that's how I ended up with Dr. Deveney. And then things evolved into, you're a candidate for this type of surgery, which will take care of your problem.
Yeah, so maybe we can talk a little bit about this kind of surgery and what it is. And I know, Bob, you have a model to show us.
Sure.
And maybe that would be the best way to sort of launch into
Sure.
the description.
For John, he has a type of arthritis which is common, but not as common as some of the other types that we see. And specifically, the arthritis that he was suffering from was isolated to the end of the thigh bone and the backside of the kneecap. And in the past, we have always had surgical procedures to address that. However, the results were not always as favorable as we would like. It was good, but perhaps not as good as we would like. So, as a consequence of that, many patients who had arthritis isolated to this portion of the knee would very commonly have a total knee replacement rather than a partial knee replacement. Mm-hmm. So what we're talking about today is something called Makoplasty, which is a robotically assisted surgical procedure. It gives us the ability to do surgical procedures even with greater accuracy than we've done before. And in that setting, many more of our patients who would previously have been candidates for total knee replacements are now candidates for partial knee replacement. So this is a model of the knee, and this model...
The person is attached to the top part there.
Yes, correct. Yes, correct. Okay. This model... Sorry. This model has a combination of two types of partial knee replacements, and I'll cover this part. This is more traditionally a partial knee replacement, and that is covering just a portion of one side of the knee on the thigh side, the femur, and one side of the shin part, which is called the tibia.
So this is where you said John's arthritis was sort of localized to. That's the area.
No.
No. Okay.
Because
Good, see, I'm glad I asked.
That's okay. Because this is combination, I wanted to first show that. So now what I'll do is I'll cover that. And for John had arthritis just at the front end of the thigh bone and the back side of the kneecap.
Okay.
So what you're seeing here, just this portion, is the patellofemoral replacement, where we're putting a new surface.
And that's where the patellar bone, the kneecap, slides up and down on the femur, right?
This is the back side of the kneecap, and you can see it articulates or moves against that portion of the femur.
So that's the crunching sounds that you were hearing as you were going up and down the stairs.
Yes. And for individuals who have this type of arthritis, they typically complain of terrible pain on stairs, getting up from a seated position. Mm-hmm. If they're in an airplane, they love to have the aisle seat because they want to get their leg out into the aisle. If they're in a movie theater, same thing, they'll sit in an aisle seat, because if you sit with your knees bent for any length of time, they have pain.
Because you've got the arthritic patellar surface
rubbing up against.
Rubbing on the silver surface there of the femur.
Right.
I actually had that for a period when I was skiing a lot. I do ski a lot, but thigh strengthening helped.
Correct.
And I'm sure that's the first thing that everybody does.
Yes. And for patients who have this, much as John said, he had treatment of varying degrees over a period of time, and they work, but as the arthritis progresses, it becomes less and less helpful, and eventually gets to the point where patients will come in and say, I'm not having any relief at all.
Right.
Now, this robotic surgery, though, is really interesting because it really reflects the most modern of technology, our ability to create three-dimensional radiographs from CAT scans and then to translate that into guiding your hand. And maybe you could say some of the problems with the old approaches to joint replacement and partial joint replacement.
Everyone is familiar with hip and knee replacements, very, very common, very popular, and very successful. And we've always been able to do these procedures very, very accurately. The robotic assisted surgery brings us to a new level whereby preoperatively we plan in a three-dimension image. Previously, planning for surgical procedures were done by X-ray, which is two-dimensional. For patients who have Makoplasty, this robotic assisted surgery, they are actually planned. Our planning is done by a CAT scan, which gives us the ability to preoperatively, before we actually enter the operating room, to determine the exact position and placement of the components. The added benefit is that at the time of surgery, we're able to interactively confirm that what we have planned we're executing at the time of surgery.
Okay.
And the overall goal of this is to be able to place the components in an extremely accurate position, because by doing so, it helps in function and longevity of the prosthesis.
And that's an important point to make. So we anticipate that by the robot helping to place these components so precisely, John will get a much longer lifespan out of his knee replacements than he might have otherwise.
Yes, we do anticipate, and the reason why we say that is that we know that a well-positioned, well-aligned component tends to function better over a longer period of time. So by doing this, if we're able to increase our accuracy even further, that's what we're hoping for, and that's what we anticipate.
In the old days, 2 years ago, or 3 years ago, you had to do this using two-dimensional X-rays. Is that right?
That is correct, yes, which was good, but this brings us to another level of accuracy.
Yeah.
I think the other thing, wearing my old engineering hat, which is really old at this point, but small differences in angles and alignment make big differences in pressure transmission through that joint.
That is correct, and that's the goal. As I said, we have always been accurate, but this is bringing it to another level of accuracy. And like in every industry and in everything that is currently done, everyone strives for better accuracy, better reproducibility, and that's what this gives us the ability to achieve.
I'm sorry, what does this mean for the patient in terms of recovery time? John, how was your recovery, and how was your whole experience?
It was very fast. The surgery was one overnight stay in the hospital, a brief session with a physical therapist before I was discharged from the hospital. I started physical therapy at a outpatient physical therapy unit. About 2 days later, I used a walker to assist for about 2 days, progressed to a cane for maybe a week, and then back to pretty much normal.
Back to normal. Pain issues? Do you want to comment?
Very minor. Nothing that was at all unmanageable. Everything went very, very smoothly.
Right.
Bob, do you find a difference in recovery using the Mako procedure?
I do find a difference. The one thing that is most dramatic for John, and this is what we will typically see for our patients like John, is that the morning after surgery, when we're making rounds, I said, John, how are you feeling? And the first words out of his mouth were, that crunching sensation is gone. I don't have the pain that I've had for 20 years. So
it was immediate.
That's remarkable.
And you said the other thing that this allows you, and specifically in John's case, has allowed you to do this smaller procedure, the patellofemoral replacement, rather than a larger knee replacement.
Correct. John's surgery could have been done with traditional instrumentation, but more often, many surgeons will lean more towards a total knee replacement because of some concerns about our ability to be as precise as we would like. So with the robotic assisted surgery, we're now able to confirm intraoperatively that yes, we are doing what we're...
Just tell me, we've run out of time, but I'm still really interested in how does the robot help you make the right cut?
Okay. The robot is an instrument, it's a tool. So patients will often ask, is the robot doing the surgery, or are you still doing the surgery? And I can assure the patients that I still do the surgery. Basically, it's an instrument that's introduced to the surgical field that gives me the ability to resect the minimal amount of tissue or bone that we need to and confirm it intraoperatively while we're doing it. And it also has a built-in safety measure so that it will prevent you from extending beyond where you
So
should be.
does the
So it's
robot
really a
grab your
safety-
hand, or do you use the robot?
We actually hold the robotic arm and we control it. But if there were a circumstance in which you were to, if you would wander from where you should be, it shuts off.
It would
immediately.
redirect you.
Exactly.
Oh, okay. Wow, this has been really informative, and
Yeah.
we thank you both
Amazing
for coming
technology.
on.
How do you feel?
Feel very good. I'm looking forward to being able to ride a bicycle again and walk down a slope without having to sidestep and things like that. And
Terrific.
The
So we've got
crunching
a
is-
happy,
the crunching is
satisfied
gone.
customer there.
Yes.
And people, are these widely available, these robots?
Currently, there are only 2 in the state of Connecticut. There are other units in other parts of the country, but it's an evolving technology.
Yeah,
So
and
they
that's
can
all we
reach you
have time for.
in Danbury. Yeah, we've got to.
Yeah.
They can reach you at Danbury.
Great. Well, thank you.
Fabulous.
Great.
So I want to thank you both, and we'll be back after a short break to discuss the same issue with another patient and his surgeon. Great.
Well,
Hi, Vicki and I are back with Dr. John Dunleavy. He's a total joint specialist and hip and knee surgeon with Danbury Orthopedists, and his patient, Jeffrey Tracy, who's been the recipient of a new hip.
welcome. Thank you for coming on Health Talk. And we'd love to hear your story, Jeff. You've had your hip done fairly recently, and that was because I'm guessing that you were having some degree of pain and discomfort over some period of time that led you to this gentleman.
Yes. Last several years, arthritis. Difficult to sit for a long period of time. Difficult to play 18 holes of golf, walking, and
Sure.
stuff I would normally do became very uncomfortable. And
What finally pushed you to see an orthopedist?
it got to the point where it was uncomfortable all the time, and I figured there had to be some kind of a fix out there, and I was lucky enough to find Dr. Dunleavy.
Were you worried about the procedure? I'm sure you had some questions and hesitations, like we all do when we're faced with surgery. But anything specific that he was able to sort of allay for you, or?
You know, honestly, I didn't have worries.
Mm-hmm.
These guys are very professional, and when you walk in there, you get a level of confidence. I think I wasn't worried about it.
That must be great to hear, John.
It's wonderful to
Putting
hear.
patients at ease when they walk in needing a hip replacement, I think, is a very, very special skill. So keep up the good work. But you know, joking aside, I mean, this is still you know, I don't want to say a significant surgery, but it is a surgery that comes with you know, some recovery period involved, et cetera. But now there's actually a better way, right? We've been talking about the Mako robot and Makoplasty for knees in the earlier segment, and now maybe you can tell us a little bit, or maybe we can even pull up some
Yeah,
images.
you brought along some slides, which I think will make it real for
Yeah.
the people at home.
Yeah.
But how you use this high-tech three-dimensional planning to improve the result. So
Yeah, let's take a look at some pictures.
So this is the Mako robot.
So this is what the robot actually looks like. The machine is in the operating room with us. It does not perform the operation. I do, but it certainly assists. And we'll go on to the next slide, which shows a screenshot of the three-dimensional CAT scan image that's been used to plan the surgery. As you can see, that's somebody there looking at that image before they've even gone in the operating room.
And that's
so
really
what's
sort
that
of-
green stuff there in the middle?
So the green that you see is representative of the specific amount of bone that's going to be removed during the operation.
So using the
okay.
CAT scan image, the CAT scan generally has the ball right at the socket. Does the CAT scan by computer remove the ball so you can look just at the socket? And is that
That's
what we're
right.
looking at here?
Yeah.
That's right. The CAT scan allows us to plan out where the socket is going to go and where you're going to be putting the ball. And the relationship of the two, of course, is critical
Right.
to get correct in terms of executing
So
the
this
surgery.
seems to me like paint by numbers. Wherever the green is, you grind away. Don't let Jeff hear this.
That's right. That's essentially correct. And so it's certainly my job to make sure that that plan is accurate and is appropriate. And of course, we do that before we ever go in the operating room.
I think
So
for
this is
people
the
at home,
planning stage.
they just can't appreciate just how fabulous it is. Fabulous to get these three-dimensional images without any cutting. You can see what the joint looks like before you go in.
Right.
So go
What do
ahead.
we
So
have next?
That's
next
right.
slide
And we'll
is-
go to the next slide. And this is a cartoon showing how the robotic arm is brought to bear in the operating room. And there's the tool attached to it. It's really very similar to the tool we would use when we do the surgery without the assistance of the robot. But
And is
this,
that a handle there that you grab your hand on? It almost looks like a gun or something where you can grab
like a
that
water
handle.
hose.
that is exactly what it is. It is a handle, and that is essentially a power tool.
Yeah.
That is what we use to remove, again, just enough bone. We don't want to remove any less than we need or any more than we
And
need.
there's a little piece of metal going towards the top of the screen. Is that the piece that's attached to the robot and sort of keeps you within bounds?
It does, and if as we're using the instrument, if we take even just a little bit too much, the robot will turn off. So there's a built-in safety mechanism to it.
That's great to
Now,
know.
if we can go to the next slide, I think we'll see how. And you can see here, this is what it looks like during the surgery on the screen. That green that we saw earlier is now disappearing.
Is this
Yeah.
what you see in the OR?
That's exactly
Wow,
right.
I think I could even do this.
And so that's right. So when the green is gone,
Yeah.
you've
Then you know that
taken
you're-
just the correct amount of bone, and you can feel very confident that you've done so in a way that will allow you to place the implant in an optimal position.
Wow, that's really amazing.
Let's see the next one.
And this is just a picture of somebody's hip with an arthritic hip there on the right side of the screen, the patient's left hip. And if we go to the next slide, it shows the end result. That is where the ball and socket joint have been replaced, a total hip replacement, just like what Jeff had.
So
Right.
what did you think, Jeff, when you heard about this robotic approach to replacing your hip?
Well, I was very comfortable before the robot was introduced. And the Monday before the surgery, Dr. Dunleavy called me and asked me if I would be interested. He explained, what the situation was, and it sounded reasonable, increased accuracy,
Right.
and we agreed it was a good idea. So that was Monday morning. Tuesday morning, I went for a CAT scan, and that Friday, it all came together.
Well, let me ask this then who wouldn't be a candidate? Because it sounds like, greater accuracy, who doesn't want that, right? So are there other criteria that make you choose or discard patients for this particular procedure?
Really, there are very few reasons to eliminate someone as a candidate for this. I think there are certain cases where the logistics just don't work out. They can't seem to get the CAT scan in time, but to be honest, there are very few reasons not that it couldn't be done.
Okay.
Yes, in the OR, do you ever use the robot to guide that depth so you're sort of pushing up against the edge and do you use that guidance or you just try to stay within the parameters? of
Well,
the
actually, the robot keeps you within the parameters to a certain extent, and it provides feedback. And when I'm actually there holding the instrument, if you're leaving the comfort zone, it'll turn off. And it'll also give you a little resistance. And so really, it's going to keep you in that sweet
So
spot.
a great safety measure right there. Now, I
Does
know
this make
that
a good surgeon great?
Well, I think that's an interesting way of putting it. The fact is that without the robot, we still were getting wonderful results and still are getting wonderful results. So how do you improve upon a 96% or so success rate? This is maybe one way to maybe do that.
This is
Sure.
sort of amazing technology. It's really,
it really
mind-blowing.
is. And I can see this becoming the new standard as these robots become more prevalent, I would imagine, although I'm sure on the cost side, it might be a consideration.
Yeah, I think at this point it's still up and coming,
Right.
and I do think there's a lot of interest out there. There's certainly not necessary to achieve a good outcome.
Right.
But again, as you said, who wouldn't want that level of
And
accuracy?
Jeff, we
Absolutely.
run out of time. Final words?
Uh,
Did you do a good job?
He did an outstanding job.
So
I
you're
would
feeling
highly
better?
recommend. I feel great.
That's
Yeah, that's
again
great.
another happy ending.
Yes.
So thank you both for coming on the show. We need to take a short break. When we come back, we'll talk to another orthopedic surgeon on the benefits of joint replacement and the robotic assisted Makoplasty.
We are back with Dr. Sanjay Gupta, orthopedic surgeon with Orthopedic Specialists of Connecticut, and his patient, Valerie Ward. Welcome.
Sanjay, the first question, you're not the Sanjay Gupta of CNN fame. You're not a neurosurgeon, you're an orthopedic surgeon.
Yes,
So
yes, thank you.
we have our own Sanjay Gupta here.
Yes, we do. So tell us a little bit about, or Valerie, maybe you can tell us what type of issue you were having with your knee and how you came to have this particular surgery.
Well, I had a lot of pain that had built up and intensified over the years. And then I had a sort of a little event last year in April, which I tried to work through with yoga and Advil and a heated blanket and some massage and all that sort of thing. It became very difficult to walk downstairs towards the end of the year, and I knew that I really needed help. And I had a doctor send me for an MRI. And when he explained what the MRI showed, I knew that I needed to start looking for a surgeon.
Yeah, and that led you to Dr. Gupta.
It did.
Yeah.
I had a number of referrals from different friends and friends of friends. And
Did you know about the robotic procedure when you sought him?
no,
Dr. Gupta
no,
out?
I didn't. I had done some reading, and I'd had some, friends tell me that there were many different procedures available, and I shouldn't rush into anything. And I had 3 appointments. Dr. Gupta was the first person I went to see, and I then canceled everything else.
Well, that must be nice to hear.
No, thanks to
Now tell us a little bit about, and maybe you can show us with some of the models
Right,
that you
what
have here, what the problem was and how we
Yes,
fixed it.
essentially, if you look at a normal knee, you have the thigh bone, the shin bone, and the edges of the bones are covered with cartilage. And they are almost frictionless when you're only active, and it's pristine cartilage, so you don't really know.
No, we're missing the kneecap there.
Yeah, so you're
correct?
missing the kneecap here. So the knee has 3 rooms, one on the inside, one on the outside, and one in the front of the thigh bone behind the kneecap. So that's the 3 rooms. And what Valerie had is her outside room was fine, or the outside compartment was fine. The back or the front of the knee was fine. She was really missing the cartilage on the inside of the knee. And she had tried pretty much everything. So in the past,
So the cartilage, just to point out for people at home, is the lubricating surface that
Right.
allows these things to slide one on the other. And once it gets worn away,
It hurts.
It hurts.
Yeah.
Right, because you're really grinding bone on bone, and you hear this pain and cracking, and no matter what you do, especially if you go for a long walk, going up and down the stairs,
Sounds
this pretty
pretty
much
familiar.
hurts
Yes.
Yeah.
all the time. So once we came decision to do surgery, the idea is, if the other 2 compartments or the rooms are healthy, this should really preserve that and just operate or replace the room or the compartment, which is arthritic. And the benefit of doing that is, it's a less invasive surgery. You put less metal work into it. And you also preserve, but also what is preserved in a partial knee replacement, there are 2 important ligaments in the middle of your knee. They're like a cross known as the cruciate ligament.
Yeah, everybody knows ACL.
Right.
The anterior
There's-
cruciate ligament.
Absolutely. So there's ACL, and there's one in the back called the PCL.
Right.
And they perform very important function, not just with balance, but also sending a feedback to our brain system, knowing where our knee is in space, and having that balance proprioception, as they call it, to have that feeling that your knee is natural, belongs to you. In a partial knee replacement, those 2 ligaments are preserved.
I didn't know that.
Yeah. And because those
With a total knee replacement, they're totally gone, right?
Right.
Because it's all prosthetics.
It's all prosthetic,
Okay.
right? So just to give an example, this is what is a total knee replacement. With somebody who has arthritis throughout the knee, then you really replace the inside of the knee, the outside of the knee, and the front of the knee and the kneecap. And you can see the ligaments in the middle.
They're gone.
They're gone.
Yeah.
So it doesn't hurt, and it's an excellent operation, but it's a much more invasive, a lot more metal work, longer surgery. The rehabilitation is much harder on the patient. It takes really 6 to 8 weeks to get back to sort of pain-free, active life.
So here you make it very, very specific, very tailored. You're
Right.
just fixing that spot.
You're just fixing a lot less metal. You're just
Yeah.
fixing the inside, which what Val had, and you're preserving the ligaments, which is in the center.
Yeah.
So the knee feels much, much natural.
And the recovery time for this
For
versus
this,
the total knee?
total knee, you typically stay in the hospital for 2 to 3 nights after the surgery. Most 70–80% of the people will go home. Some percentage of people will go to a nursing home or a rehabilitation facility. With a partial knee, it's a same-day surgery.
Okay.
So within less than 24 hours, you're back home.
And did the robot facilitate your ability to do this?
Absolutely.
Would you have been able to do that on Val without the robot system?
I would have, absolutely. I mean, the concept of the surgery is really not new. It's been around for 20, 30 years. But if you look at what happened in the past is the knee is a three-dimensional structure. And we planned the surgery on an X-ray, which is a two-dimensional. So there's always that subtle variation between our planning and our execution in the surgery. And in surgeries, we have various tools to make sure that, for example, this piece has to sit, this piece which sits on this shin bone has to be perfect. Now, may not be perfect, certain percentage, we can do it slightly this way or this way, and in three-dimensional it might be different.
So the robot makes it so that your precision is spot
And we have
on.
like 20
Absolutely.
seconds left,
Yes.
so I just want to ask Val, so the outcome, are you happy?
I'm euphoric.
That's a
As I
great
say,
word to
Oh.
hear.
I'd become, somewhat inured to this constant sort of burning, aching sensation, but it had intensified dramatically.
And now you're,
And now you're better.
that is
It's
it's
amazing.
wonderful to hear. Sorry we don't have more time to
No,
hear
thank
about
you.
this.
Thank
That's
you.
about all the time we have for today. Thank you so much for coming on the show. Vicki and I want to thank both of our guests, or I should say all six of
All
our
six
guests.
of them. And Eric and I will see you next week on Health Talk. Stay healthy.
Bye-bye, stay well.